want to welcome everybody to the Advanced PCI Summit, Algorithmic Approaches to Complex PCI webinar series. This first webinar, Navigating the Complex PCI Landscape, Anatomic Complexity, Complete Revascularization, and Mechanical Circulatory Support, is being hosted by Dr. Kevin Croce, who is the Director of the CTO and Complex Coronary Artery and Intervention Program and the Translational Discovery Laboratory at Brigham and Women's Hospital, affiliated with Harvard Medical School. The panelists for this are Dr. Kathleen Kearney, Assistant Professor, Division of Cardiology, University of Washington School of Medicine in Seattle, and Dr. Lorenzo Azzalini, the Director of the Complex Coronary Interventions at VCU Health Pauley Heart Center and Associate Professor of Medicine at Virginia Commonwealth University. Please feel free to ask questions in the chat, as we will have a question and answer session at the conclusion. At this time, I'd like to hand this over to Dr. Kevin Croce to lead us through this webinar.
Welcome, everybody. Glad to see you here. Thanks for spending your evening with us. We're excited about this program, which is focused on complex PCI. I'd like to thank Josh, Lorenzo, and Kate for being here. Kate's going to be a few minutes late because she's just finishing up a case, being on the West Coast, and it's only about 5 o'clock her time. So tonight we're going to talk about complex PCI. I think the bulk of the presentation and case discussion is going to be handled by Lorenzo and Kate. I just have a couple slides that sort of set the stage for the evening. One of the cool things which Lorenzo is going to review in detail is really, what does CHIP mean? How do we integrate it? And how do we start to apply rational approaches to CHIP patients? Really integrating what we know is anatomic considerations, comorbidity considerations for the patient, and sort of how we deal with getting patients through revascularization or a shock procedure safely. And things which we know about these patients is, surgical ineligibility, kidney disease, and impaired LV functions are the main things which portend really large increases in mortality. And working toward complete revascularization, appropriate plaque modification, and how do we treat patients that have valvular heart disease are all really forefront and center in integrating the various considerations with regard to who gets treated and how we best treat them. And I think there is certainly still in the United States an under-treatment of these patients, because we're still growing a base of physicians that have the expertise to be able to treat patients with these significant comorbidities. You can't give a complex PCI talk really without giving nod to the fact that heart team practice in this space is certainly best practice. There was another report out this week. It was observational, but it did show that there tends to be a benefit with regard to less mortalities when complex PCI and shock patients are treated in a center that has a heart team. And I think it allows us to work with our heart failure colleagues, our clinical cardiologists, and our surgeons to really try to develop best practices. And this is something that Kate's going to touch on in terms of how they've been able to make progress at UW, where she practices. And all over, if you think about, what drives patients to PCI or to CABG in the context of a heart team, this is a really nice paper which my colleague Farouk Jaffer, who co-directs our complex PCI fellowship program with me across our health system, he published, really nice observational data which demonstrated that it's really not the complex anatomy that drives patients to PCI, it's actually the comorbidities. And I think looking, a lot of times the patients get referred to us for revascularization because their comorbidities really drive them away from being able to get through a surgical operation procedure with any sort of quality of life or quantity of life on the back end. And so with that in mind, I think there's a lot of movement toward evolving best practices and amassing data in the complex PCI and CHIP space. And so Lorenzo is going to kick it off with a nice review of that now. Thanks, Lorenzo, for being here. Excited to converse on this and learn from you this evening.
Thank you so much, Kevin, to pave the way for my talk. You have just made my life a bit easier. So we're going to talk about the complexity of the coronary anatomy and the challenges and especially the importance of achieving complete revascularization in patients with complex coronary disease. These are my disclosures. So I'm going to kick off this talk with a couple of cases. Okay, so this is a 68-year-old man with several comorbidities. He was known to have severe CAD because he had refused CABG 1 year before the current presentation, when his LVF was normal 55%. Now he comes in with overt heart failure and STEMI, and LVF has now dropped to 20%. And this is the echo. So you can see here the coronary angiogram from 12 months prior that shows moderate left main disease, ostial LAD stenosis and also critical mid-LAD disease involving the diagonal. There is severe calcification, and also there is a first marginal branch lesion. This is a shot of the right, severe calcified disease on the and diffuse disease on the RCA. The STS score is 6.5%, SINTA score is 51.5. The patient, despite all these scores, refuses adamant in refusing CABG again. We perform a right heart cath that shows that he has a low cardiac index, just 1.4, despite the fact that blood pressure is normal, and he has a very high LVP of 26 millimeter of mercury. We're going to see what we've done with what we did with that case later. I'm going to present another case, case number 2. This is a 80-year-old female presenting in the outpatient clinic with stable angina, class 3, and inferior anteroapical ischemia. She has a mild to moderate CKD, LVF is normal, the SINTA score is 38 because she has a proximal RCA CTO that is severely calcified. And then she also has severe calcification and critical disease on her LAD from proximal to mid that also involves the first diagonal branch. So the questions are in these two cases. For both cases, should we achieve revascularization in just one procedure or in a staged fashion with 2 or more procedures? In the case number 1, should we treat all 3 vessels or just the LAD and the RCA? Do we need any extra devices like atherectomy devices or mechanical circulatory support? In the second case, what vessels are we going to treat? If both the LAD and the RCA, where do we start with which one? Do we need to treat the RCA CTO as well, or can we leave it alone? What are the indications for this CTO PCI? Do we need atherectomy on the LAD, on the RCA, or on both? So this brings us to talk about what is complex PCI. Are we talking about complex patients with advanced age comorbidities like renal failure, LV dysfunction? Are we talking about complex lesion, calcification, bifurcation, left main, ISR, CTOs, etc.? Or these are just complex procedures with need for atherectomy, two-stent bifurcation PCI, need for imaging, etc. No matter, there's no official definition for complex PCI. I just think that it's a mixture of all these factors: complex patient, complex lesion, and complex procedure. And this increasing complexity of the patient that are being treated in the cath labs nowadays is also mirrored in the research in large registries. There is an increasing prevalence of type C lesion, severely calcified lesion, left main disease, and also the mean mortality risk score of our patient population is steadily increasing. It's important to know that these patients sometimes, actually often, are surgically ineligible to undergo CABG. And if this patient undergo PCI, we have to be prepared to see an increase in the rate of both on the short and long term of mortality of this patient population, because these are patients with a lot of comorbidities compared with bread and butter PCI in surgically eligible patients. What are the criteria that make these patient surgical turndowns? So in this study from the Harvard group, it's especially the presence of poor targets and conduits, and also advanced age, as well as certain comorbidities, first and foremost, renal failure. So we have here a conundrum. So the indication for revascularization do not change depending on the complexity of the lesion. So just because the lesion is harder to treat, we decide not to treat it. And so this equation between the risk and benefit can be modified to our favor, actually to our patient's favor, with enough technical expertise, with updated devices and technology, and appropriate patient selection. So in the CHIP space, we are witnessing a paradox where the higher risk cases are those who would benefit the most from revascularization, but at the same time are the least likely to undergo revascularization because of fear of complication and bad outcomes. So our goal should be to promote complete revascularization and to reduce inappropriate omissions in care, because not only poorly indicated procedures are bad, but also inappropriate omissions in care should be avoided. So what is CHIP in my institution, Virginia Commonwealth University? So for short, CTO. CTO is a different animal, requires technical expertise and dedicated devices. for sure also atherectomy, any kind of atherectomy, rotational, orbital, or laser, and intravascular lithotripsy. If the patient needs mechanical circulatory support with Impella, if we are performing an unprotected left main PCI or a bifurcation with a two-stent strategy, or again, ultra-low contrast volume PCI. And in our program, we put a strong emphasis on intravascular imaging. So in all these settings, we use imaging, both OCT and IVUS, a lot. So the critical questions in the field of complete revascularization are the following. How do we define it? How hard is it to achieve complete revascularization? What is the association between complete versus incomplete revascularization with outcomes? What are the mechanisms underlying improved outcomes with complete revascularization? And then the dilemma, if we should pursue complete revascularization with just one procedure or in multiple procedures. Complete revascularization tradition has been defined as achieving revascularization of all lesions with at least 50% diameter stenosis. And the prevalence of complete revascularization is highly variable in the literature. In randomized trial, the prevalence is higher, particularly for CABG treated patients, but also with PCI, it ranges between 50 and 70%. Whereas large real-world data from the Mayo Clinic and New York State registries are lower, indicating that the prevalence of achieving complete revascularization is just between 30 and 55%. So it's quite actually hard. It's in a minority of patients. And we know that one factor that handicaps our ability to achieve complete revascularization is the baseline CAD burden as assessed with the baseline syntax score. We know that patients with the intermediate, especially high syntax score greater than 32, are least likely to receive complete revascularization. A few years ago, this is a study from the Acuity trial, where the concept of residual syntax score was developed. So residual syntax score is the syntax score that is residual after performing PCI in this case. So is what we're not able or not willing to treat. So a residual syntax score of 0 is complete revascularization. It's been shown that patients with a residual syntax score with between 1 and 8 have similar outcomes, more or less, to those achieving complete revascularization. So what we have to avoid is the presence of an incomplete revascularization or a residual syntax score greater than 8, because these patients are those that will suffer the highest risk for both mortality and MI during follow-up. This data has been replicated in other studies, also in the original syntax trial, and we know that incomplete revascularization, residual syntax score greater than 8, is associated with higher mortality and incidence of major adverse cardiac and cerebrovascular events after PCI. There is some randomized data too. This is data from the complete trial, patients presenting with STEMI and having multivessel disease that were randomized to complete revascularization as opposed to culprit lesion only PCI, enjoyed lower cardiovascular mortality and MI on follow-up. And similarly, and this is a study from a large British registry, patient presenting with NSTEMI and multivessel disease suffered lower rate of all-cause mortality on follow-up if they receive complete revascularization versus culprit vessel only intervention. This is adjusted data from an observational study. Countless of studies, very large patient population overall in a meta-analysis, 90,000 patients enrolled in trials and observational studies, very strong signal towards very strong evidence of association between complete revascularization and lower mortality. Interestingly, what is the predictor of the most important predictor of not being able to achieve complete revascularization in patient undergoing PCI? It is the presence of a total occlusion, and in particular chronic total occlusion. And again, this is not surprising because we know that these lesions are a different lesion subset and require very specific training and devices, and also commitment by the institution to achieve a revascularization. What are the mechanisms underlying, I skipped the slide, So what are the mechanisms underlying the benefit of complete revascularization in our patients? So we know from this historical study from the Achamovich series in 2003 that patients with a greater burden of ischemia, more than 20% of the LV mass, will enjoy better mortality rates on follow-up compared with PCI compared with medical therapy. And this signal is already present after above 10% of LV mass. Another mechanism that is strictly correlated to the previous one is the improvement in left ventricular ejection fraction. So we know that patients with LV dysfunction and multivessel disease, if they're treated with extensive revascularization, in this case, this is an Impella-treated cohort, they will enjoy a better improvement in LVF, and this improvement will be higher the higher the number of treated vessels. So patients with 3 vessels treated will enjoy greater improvement in LVF compared with patients that were just treated on 1 vessel. Finally, the question about the dilemma about stage versus one-step revascularization. This is a highly confounded field of research. So this is a sub-study from the Syntax trial, the original Syntax trial. So stage PCI was discouraged in the Syntax trial, and most cases should have been revascularized in 1 setting. However, particularly in patients with higher comorbidity burden and higher risk of AKI, staging was allowed within 2 weeks from the randomization. And so these patients with stage PCI suffered higher risk of MACE at 5 years follow-up compared with single session PCI, but this is obviously not surprising because, as mentioned, this patient had higher comorbidity burden, more lesions, higher prevalence of severe calcification, CTOs, and bifurcation. And this is what was associated actually with lower prevalence of achieving complete revascularization that intermediated the effect on the worse outcomes on follow-up. Other observational study from the VA CART, so the Veteran Affairs Registry in the US. So this study found actually completely opposite findings. So in this study, stage PCI was actually associated with lower mortality in all patients and also across the board in STEMI patient, non-ST elevation ACS, and stable CAD. The decision to perform stage PCI was, however, driven by a lot of procedural characteristics and a measure of side factors that when the author analyzed those were actually the most important decision-making item, skewing their decision towards either complete single step versus stage PCI. There is another trial in this space. It's called the SMILE randomized control trial. About 500 patients with STEMI, they were randomized to either a 1-step revascularization during the index procedure or stage PCI within 3 to 7 days. And stage PCI was associated with a higher 1-year MACE compared with single session PCI. However, the mechanisms are unclear. Even reading the discussion of the paper, the authors were not sure because the results were exclusively driven by a higher incidence of TVR after 5 to 6 months. So if we consider that the goal in both groups was to achieve complete revascularization, this does not explain the increased mortality with stage PCI. And again, like in many randomized controlled trials, the patient population was rather simple with just a mean Syntax score of 16 and a almost normal LVF of 50%. So in this case, the stage versus single session PCI dilemma, this is my perspective, and these are just class C recommendations. So C is for common sense. So I think that it's reasonable to pursue single session revascularization in case we have focal lesion or at least simple lesion in multiple vessels, or there is no left ventricular dysfunction and the compensation. So we should measure LVDP in all our cases, especially the complex ones like these ones, unless mechanical circulatory support is planned. In that case, it's reasonable to pursue single session revascularization, because if we stage the procedure, we will have higher risk of vascular access complication and bleeding, because again, if we go for just one procedure, we will have just one vascular access, and we know that one vascular access once is better than one access multiple times. In case in other situation, I recommend to pursue a stage PCI, particularly if we have complex lesion like CTOs. CTOs need to be focused on in a single procedure, or in case we have left main disease and also RCA disease. So it's not practical to go back from one vessel to the other, change guides, taking more diagnostic shots. And then in case of complex bifurcation requiring two stent strategies and in patients with severe LV dysfunction and normal right and left heart cath, unless we use mechanical circulatory support. Also, we should stage our procedure in case of high-risk patient conditions like advanced age or CKD, another risk factor for AKI. And for sure, in all cases, we should put a strong emphasis on intravascular imaging in all these complex lesions. So answering the questions that I posed initially, the definition of a complete revascularization is a residual symptom score of less or equal to 8. Only 31 to 55% of cases in the literature receive complete revascularization, and the complete revascularization is harder to achieve the higher the baseline CAD burden as assessed with the symptom score. Incomplete revascularization is strongly associated with adverse outcomes, although the evidence derives mainly from non-randomized data. The relief of ischemia and improvement in left ventricular ejection fractions are the mechanism underlying these improved outcomes. And regarding the dilemma between single stage versus stage procedure, this is a highly confounded field of research, and the jury is still out, and there should be higher quality research. So going back to our cases, the first one is the lady, is a gentleman, 68-year-old with severe LV decompensation and LV dysfunction. We, the right heart cath was severely abnormal. We proceeded with a single stage PCI with impella mechanical circulatory support. We use atherectomy in both the LAD and the RCA. We achieved a good result with a residual symptom score of 2. And in this case, you know, we have to keep in mind that these procedures are quite laborious and expensive, and it's a great commitment by both the cath lab team and the operator and the hospital administration. So we require 1 impella, 2 guide catheters, guide catheter extension, multiple wires, a dozen balloons, orbital atherectomy, couple microcatheters, 8 stents, imaging catheters, 1 Gant, and 3 vascular access closure devices. The reward for this effort was that 6-month follow-up, the patient is completely asymptomatic. The LVF went from 20%, back to 45%, almost normal. So a very good result also on short-term, mid-term follow-up. And the second case, this is the 80-year-old lady with the RCA CTO, severely calcified LAD. First procedure, she was an elective patient, and we had RCA CTO, so we decided to stage the procedure also because she had no LV dysfunction. And this is a result first on the LAD, and then the result on the RCA CTO. Residual symptom score of 0, and the angina went from CCS class 3 to just class 1, so she's almost asymptomatic. And again, very expensive procedures. So first procedure, 2 sheath, 1 guide catheter, several guide wires, a dozen balloons, 2 atherectomy system because orbital atherectomy was unsuccessful. We required rotational atherectomy with a 2 burst, so we also had to go femoral, and 2 stents in the first procedure and the imaging catheter. Second procedure, traditional CTO PCI with 2 sheaths, 2 guide catheters, guide catheter extension, multiple guide wires and balloons, rotational atherectomy, 2 microcatheters, 4 stents, and 1 imaging catheter. So very important commitment by both the operator and the cath lab team on one hand, and on the other hand, the hospital administration. And this is all I have. Thank you.
Lorenzo, that was excellent. What a tour de force. Thanks very much. One thing I wanted to ask your perspective on is, you know, sometimes I gut check whether I'm going to do complete revasc in the same setting, even when I have an impella in for low EF and marginal hemodynamics, is when we're going to do extensive atherectomy. And every vessel you need to treat needs extensive atherectomy. I've gotten into trouble sometimes where the patients get pretty sick and they move on from vessel 1 to vessel 2 because of the showering and mechanical atherectomy involved. So that's something which I'll also integrate in terms of whether I stage it. I, like you, if the impella goes in, I certainly don't want to have to put an impella in a second time in the stage procedure. So I always look to get everything done, but how much roto, orbital, otherwise you need to do is something which I found to be a portender for a rockier course if you're going to do a lot of that in more than one vessel. Do you have thoughts on that?
Yeah, absolutely. I totally agree with you. Atherectomy, is extremely aggressive on the microcirculation. So I do right arc cath in all my Impella cases, and sometimes, no matter what, orbital, rotational, and also especially laser, you have this patient losing the pulsatility. It's very aggressive, and the right arc cath at the end sometimes is very shocking. You see that maybe you spend maybe 1 minute of atherectomy time, and all the parameters, this index is lower, the wedge pressure is higher, the RA pressure also increases. So I agree with you. So that first case, we were able to win the Impella in the cath lab, but there was a slight drop in the index, and we made the decision to remove the Impella also because the patient had PAD. But for sure, I was never in the situation that I had to three vessel with atherectomy in the single procedure. But probably, I think in my experience, one sometimes is already enough to to let you pause and stop and maybe schedule a second procedure.
And it's in recent era, with probably about 4 months under our belt, it's been one of the nice things I think IVL can add to the complex PCI space, is that if you're able to deliver a lithotripsy balloon and don't need to atherectomize to get it there, the potential for microcirculatory stress is less in that scenario. So we've had a couple super sick patients where I was happy to get away with IVL because I knew that the roto or the orbital wasn't going to be well tolerated. Have you bumped into that benefit yet of this new technology?
So yeah, that's very interesting. So actually, we were the first in the world publishing a case report of MCS and IVL in the same setting, and we speculated what you exactly just mentioned. So it's true that there is no micro embolization in distal vasculature. However, if you're gonna deliver all, for example, 80 IVL shocks, you're doing 80 full seconds of no flow time in the vessel. So how much that impacts on the right arc cath and the hemodynamics overall remains to be seen. But we also started recently with the coronary IVL catheter, and surely we're going to have a lot to talk about in the next few months and years.
Great. Kate, welcome. We'll give you a second to get settled and answer some questions on the heels of what Lorenzo treated.
You can like see my hair sticking out.
We've all been there, finishing a case and rushing quickly to meetings, so thanks for making it. Lorenzo, someone asked a question, how do you have a heart team approach when there isn't many operators doing chip cases and the main approach is medical therapy or surgery? My answer to that was, you raise a good point. Number one, we need to train more chip docs. Number two, people need to realize what's possible, and if they can't do it locally, they refer it. And one of the most important things is, just because I, in quotes, can't do it doesn't mean it shouldn't be done. And so I think whoever wrote it with a tone probably of frustration based on either things they're seeing go to the neglect strategy of therapy, which we've all encountered. You get to a patient 6 months later and they're worse when they could have been treated earlier if they just got into a center that was willing to give them care. But moreover, I think the person who asked that question raises a little bit of a probably hopeful approach to how are we going to fix what I think is a well-recognized problem.
I agree. The purpose of these kind of webinars and this joint sharing of our case and expertise is exactly this, to show that stuff is possible in the appropriate hands. And maybe I'm not the best operator doing this technique and you are the best one out there in that technique. I can send the patient to you. It doesn't matter if it's in the same city or another state or in another coast of the country. So it's possible. Almost everything is possible if it's indicated, and we should always think about our patient's best interests.
Excellent. And then the other question which came around sort of chip planning was, when do you typically do viability testing in your practice prior to high-risk PCI in the setting of low EF? My comment was, I look at the echo. If the wall moves on the echo, I don't worry too much about it. But if hypokinesis, akinesis, or CTO, then we typically use PET, although we do have access to MRI also. Do you have an approach to that that's a little different, or is it similar?
No, I agree. I mean, I think there was a review by Galassi in European Heart Journal in 2016 that exactly mentioned what you just answered in the comment section in the chat. Also, to add, these patients very often are discussing most of the time are discussing a heart meeting setting, and many of those are surgical turndowns. Many times, the surgeons want to order a CMR, a PET, an MPI, or stress echo to assess viability on the LAD territory. And then if the patient gets to you at that point, you already have that information, you can make your decision. But Regarding maybe CTO, single vessel disease with CTO, also, they most of the time do not go to the surgeon, but at the same time, since those are more scrutinized, more heavily scrutinized procedure, you still want to have a viability and ischemia testing. So usually I see the patient before in the clinic, order the test, and evaluate with the patient, if the test is positive, these symptoms most likely are going to be caused by the ischemia, so we're going to go for it. On the other hand, if the patient is post-symptomatic or there is no viability or ischemia, it's better to manage with medical therapy.
Excellent. Super. Kate, any comments on that before we kick it off with your section?
No, I totally agree. I think a lot of times viability seems to be used as an excuse not to do something that we already don't like the looks of. So I think, Eric Velasquez has run a lot of the Stitches trials. It said it's one of the few tests that we actually use greatly out of proportion in those with a lower socioeconomic status and other kind of generally underserved groups. So I think keeping that in mind, but definitely if you look at the echo, if their EF is normal and they have angina, we don't go that route. But if there's concern or certainly multiple targets and we're trying to figure out what to prioritize, I think it can be helpful.
Great. And having seen your office many times in this format, I'll note that the sticky notes behind your wall are now gone.
They did go away. Nothing went in its place, you'll notice.
Awesome. Well, do you want to bring your slides up and kick off your section, Kate?
Sure, let's do it. Well, thanks all for tolerating me, I should say. In general, can you see those okay?
Yeah, can you switch it to the you're in presenter mode on the shared screen?
Sorry, I plugged into my other thing real quick.
Thanks.
Let's try that again. So actually the case I just did is very relevant to this topic because the gentleman with really bad anatomy and, I sort of would say it was on the kind of one end of the spectrum in terms of cases where I did decide to use hemodynamic support, but I think there's many cases where, just looking at the angiogram, it's hard to say. You kind of have to put more pieces of that into it. And one of the reasons that this had come up is I think we see a lot of cases posted on Twitter and other sites and a lot of sort of general hard fast rules that are put out there about like, well, this case, you have to do this. And I think it is a little bit more nuanced the more we look at that. And hopefully we're about to get more data in the next couple of years on this topic with Protect 4 and the ongoing trial in Europe. But in the meantime, I'm just going to go over kind of our practice and looking at when we use mechanical circulatory support related to high-risk PCI. Here are my disclosures. So, I think in general, there's a few particular types of cases. See if I can get these videos to play, sorry. Where, from an anatomical standpoint, I look at this and would say, sorry, these are the slides they put back together. Maybe they're warming up. I can describe here too. So this is an elderly gentleman. He comes in with an M-STEMI and a TRIP of 22, and he gets cast at one of our kind of outlier hospitals and has pretty garbagey coronaries. He does have a stent in the LED and circ from prior interventions, but his dominant circ is pretty ugly looking. And he also has an LED that here in our setup shots somehow looks worse than it did before. So it's one of those that's kind of hazy. I can't really decide how much I think that's calcium and how much maybe that's just a more acute presentation. But his hemodynamics, and we're like, okay, he's left dominant. We're going to be in his left main. He doesn't have a lot of reserve. He's ACS. So thinking about this, these are patients where I definitely skew heavily towards putting mechanical support in. On the flip side, he's 87 years old. He sort of looks like someone, if you blow too hard, he's going to fall over looking at him. But that being said, he's been very functional. We have the big conversations, and he and his family definitely want to proceed because he's having active chest pain, can't get out of the hospital. This is just definitely very limiting. And prior to this, he still mowed his lawn, played golf, living at home, wants to get back to those things. So I'd say his anatomy, sorry that these images are playing for junk, but in general, his anatomy is not favorable in terms of how much our ischemic burden is going to be and things like that. But his hemodynamics turned out to be surprisingly pretty incredibly favorable. So his RA pressure is like basically 0. He's been NPO. His wedge pressure is 7 to 8, even when it doesn't appear to be overwedged. His cardiac index is almost 3 with a PA stat of 68%. And I would put him in a higher bleeding risk category, just looking at his femoral arteries, at least on ultrasound, and sort of his other frailty and stuff. His creatinine is also about 1.8, which is fantastic. So I don't know, just stop there for Kevin and Lorenzo. Are these cases where you'd 100% use support? Do you let the hemodynamics weigh in? Or I think reasonable people disagree about what to do here. So I'm interested to see what you guys think.
Well, I mean, it's fascinating because the right arc cath is the best you can hope for, and the anatomy is horrible, and the patient is elderly. So can you also show the cranial shot? I think there is like, I mean, probably proximal LAD, critical disease, and also all the circumflex from proximal to distal has serial stenosis, and it's a left dominant. So do you, any insight? I cannot tell from the image quality, but is it a thrombus on the LAD or is it a stable lesion?
Yeah, very good question. On his initial pictures where they're having difficulty engaging the diagnostic catheter, I thought it was all calcium. When I took this picture, I thought I reconsidered that, and I think it was probably not all calcium and probably some thrombus, to be honest. Especially he had stuttering symptoms kind of ongoing, and it looked like this had evolved poorly since his diagnosis.
What I've done in the past in a case similar to this, you know, even if it's a kind of laborious, you can do a baseline IVUS, decide if it's thrombus or calcium. If it's calcium, you need a atherectomy, and so you already know it's a different ball game. So 87-year-old with proximal LAD atherectomy, maybe you need a 2 Burr, left dominance and STEMI, maybe even despite the normalcy of the right arc cath, you might decide to go for Impella. On the other hand, if it's just thrombus, maybe you also have to consider the vascular complication risk in this patient, because a high bleeding risk for sure, right? So I don't know if you had imaging available before making the decision.
Yeah, I agree with what you guys said. One of the critical components of this is I'll look at two things. You know, is extensive atherectomy needed, which may sway me at least toward having a placeholder if I don't put in mechanical circulatory support up front. And then the other thing is, you know, is the left main involved, and how difficult is the left main going to be in terms of the bifurcation stenting? You know, if you've got a difficult retroflex circ where stent delivery is going to be painful, and you're going to have balloons crossing for a long time, and the ischemic burden just in terms of the maneuvering to get the stents placed is going to be a lot. That plus atherectomy, I'd be thinking more about MCS, even if the guy's, you know, left main EF normal does in no way mean MCS, but with this degree of ischemic burden, you know, if it's super complex and needs atherectomy, I might be at least leaning toward having a placeholder for it.
Yeah, I think those are all really good points. In general, sort of game time, he's also one of these people who, you know, as soon as we get the right heart cath done, he's already a little bit restless, and, you know, he's not really agreeing with first ed necessarily. And as this is all unfolding, this is one of those where I like hip check the fellow basically out of the way as soon as we got the guide in and that was starting. Because I think time is the other factor here for sure. But yeah, I think those are really good points based on how it had evolved from his diagnostic, which I don't really have here. I thought, you know, this is probably more acute, but I had already decided that I was planning to do atherectomy. I actually don't do a whole lot of CSI, but I thought this might be a nice way to just quickly get through those focal spots, and basically wasn't engaging much in that prox LAD and was like, you know, what am I doing? That's probably all acute. So I think to Lorenzo's point, taking 30 seconds to IVUS would have been really helpful in this case, because I would have avoided all of that together. It was somewhat calcified, but that ended up being less of an issue. I think the circ certainly needed a fair bit more vessel preparation. Did a few runs of CSI there, you know, I think one high-speed run retrograde. I think sort of a focal one, you know, leaving it in there. I don't know if it's really better from an ischemic burden standpoint. I think that depends on how that all goes, and assuming you don't have issues with big dissections and reflow. But altogether, this is, you know, I don't use a ton, to be honest, but I thought this was a fairly good case for it. So we were able to move through all that fairly quickly. And then based off IVUS, actually stented, you know, quite a bit further than I had initially planned. And then, gosh, I'm sorry, I don't know if these are playing super great. But effectively, he's one where, you know, I don't know that I would do this if he wasn't about 89 years old, but we effectively landed the LAD stent back almost as a T, sort of took a puff there. So I'm going to blaze through that picture actually. That's this guy here. And I sort of do this in some of these cases where like the person's trying to crawl off the table and we're trying to be quickly, but I figure I do take an NC balloon in the left main into circ. blow that up and recross, but I figure I probably don't actually have a whole lot of stuff sticking out in some of those cases. That was all really easy to recross and get through that. And, I think if I think of myself a year ago, I would have definitely put an Impella in him. It was one of those, I was a little bit more confident that I could maybe just move very quickly. And I was worried about kind of the other effects from him and being high bleeding risk, and also just his ability to tolerate that. Anesthesia came in and put him on propofol, but he's still just, they're kind of having a hard time keeping him down. It's one of those, like, if this is all going well enough, we'll get through it. We did put a micropuncture sheath in him, which I also rarely do, because at one point I thought maybe we need to, just because he's getting so squirrely. But the benefit of the Swan is we could see he wasn't squirrely because he's getting, elevated PA pressures and pulmonary edema. He's just, not kind of uncomfortable. So I don't know that this makes, doesn't make it right or wrong. I think it's both important to consider both ways, but I think he actually tolerated it very well from a hemodynamic standpoint, probably because his reserve was much better than I would have anticipated up front. And I think to your guys' point too, it depends. I didn't end up really having to do a lot of atherectomy. The LAD was actually not as calcified as I first thought. The circ was pretty focal, and we were able to just move quickly. So I think both of those factors, and I'm sorry, I don't know if I mentioned this, but his EF was actually still normal as well. It's like about 50%. So he's a person, more acute presentation, but I think coming in more favorable and certainly higher bleeding risk. So I think just partially I present that case to play devil's advocate a little bit, that most of what we see presented is that, you always have to do that. I think it's hard to know the counterfactual. Say in this 89-year-old gentleman we just presented, we went to check on him upstairs. His radial access site, of course, looks fine. He's sitting up, he's eating a sandwich, and he has a giant hematoma from his right eye. Well, which was a little bit worrisome, but we got control of that. So I think maybe just to speak to some of those issues, that if he had had massive bleeding complications, it's one of the issues in these older folks that keep them around a little bit longer. So I think just moving through some other cases, I think that of kind of how I let the hemodynamics try to dictate my decision making, because it can be really hard. This was a gentleman who came into the ER about 5 in the morning with chest pain, was in AFib with RVR. Sorry, these aren't on replay, looks like. And had was given sedation for cardioversion and had a post-conversion cardiac arrest that was PEA, but also had a little VF in there after he's getting some drugs and CPR, and then ultimately had ROSC and is on a little bit of norepinephrine coming to the cath lab. There was concern, not so much from the EKG standpoint, although he had some ST depressions and maybe 1 millimeter ST elevations. In the inferior leads, they thought it was more that he had some ST changes and just the acuity of his presentation. And my partner who was on call, was actually flying out, I think, for one of the first meetings she was going to in COVID. So I kind of tapped in early morning as the doc of the day, and we were hearing this story and get him in. And so he has disease, apologies, angiograms are kind of hard, challenging to see. He has a little bit of a hazy lesion in his circ that I think is probably calcium, but I don't know for sure. Given the presentation, I'm worried that that's thrombotic, but he certainly has flow everywhere. And I'm kind of staring at all of this as RCA doesn't look too terrible, correctly. But he certainly has some disease down there. So sort of staring at all this and thinking about what to do. And he rapidly starts to deteriorate. So he's just progressively hypotensive and pretty shocky. I'm looking at the angiogram, like kind of weighing in my head, do I just need to do something very quickly? Is that circ going down? Picture, repeat, looks the same. But we grab an LVEDP really quick and it's almost 40. So pretty much we just rapidly put an Impella in this particular case in him. He's got favorable femoral anatomy, sat pretty well. And then everything kind of cools off. So, I think those are cases where, again, I can see myself in different scenarios being real excited about jumping in, trying to do PCI, things deteriorate. But in him, I think this was more of a hemodynamic effect afterwards. And he actually clinically did very well with no PCI done in this setting. I had actually wanted to IVUS it, and people were filtering into the lab. One of my more senior partners talked me out of it. It was like, no, that's calcium. I think the clinical scenario just doesn't really fit. And he's somebody whose EF actually looked quite a bit better. The Impella came out pretty quickly once he stabilized, but he went up on really high dose pressors and was able to come down off that. fairly quickly. So I think in him, he has coronary disease and he had a shock situation, but that was really what was driving that. And that certainly there's cases where that's more blurred about what needs to be done first. But I think he's more an example where that certainly trumped his hemodynamics, I think really trumped what was going on with his coronaries. So, I think with making these decisions, obviously we're balancing different risks. There's the ones we know, sometimes looking at the anatomy, there's all the things I know that are going to be challenging or the ischemic burden that I'm going to place on them. There's the concern for complications. Am I going to shut down a branch and have difficulty getting that back? I think, those things tend to weigh heavy on us from an emotional standpoint, where it feels like having mechanical support in might be helpful. But there's also all the things that we don't know. Their risk of vascular complications, what happens when they go back up with this on the floor. I mean, these are a lot of the patients who they stay in longer term hemolysis, and even if we're using other devices, they certainly have their risk of vascular complications. So I think, we're talking with the fellows and for myself, when these cases are, could be a little anxiety provoking, but am I treating myself with the device or am I treating the patient? So try to separate those things out, that the patient is high risk. They're based on what their ischemic burden is anticipated to be, the territory you're working at, how much that myocardium that puts at risk, as well as their other factors of hemodynamic reserve and ischemic preconditioning. I think this comes up a lot with the CTOs in low EF, but those patients have been living with this for a long time. So if you're an outpatient, not actively in shock, we can get away with a lot because your ischemic preconditioning is really high. These patients that come in with ACS or other situations that are changing rapidly can be a totally different ballgame. So I think those do factor in differently versus the case that is complex, where we're less certain about the procedural outcome, what we're going to be able to achieve potentially, different contrast limitations or anatomical ambiguity or something else about it that you don't have your full case planned out going into it necessarily. And so I think, at least from our kind of practice and protocol, it doesn't always it's not always the tiebreaker, but many times hemodynamics can be helpful, even if you use support to monitor when you're weaning at the end of the case, or if you decide to leave it in and weaning afterwards, to have a good sense of where we're starting from. And in other cases, if we decide not to put mechanical support in terms of monitoring the patients, I really do appreciate having that information during the case. Then of course, the other things we talked about, ischemic burden, atherectomy, anticipated complications. And I think I would definitely take Lorenzo's advice if I went back and did that first case again, that if I just had a better sense of what atherectomy burden I had for the case, I would have felt more confident in that decision. But I thought he was very high bleeding risk or had our risk of vascular injury. His iliacs were really tortuous. We knew from a prior case. I should mention, actually at the outside hospital, I think they had planned to do the left main intervention, went up his right iliac and dissected it, took an up and over shot, still had flow and bailed on the case. So kind of going into it, we knew he was higher vascular risk and just wanted to stay out of all of that. But it's, it's certainly a balance from that. And I think we weigh that, especially in these higher risk patients, because we know the more bleeding people have, the more other problems we have. We had our first RP bleed at this institution from a cath for a while. A few weeks ago, and the patient got through all of that, but then a few days later had a PE. And for whatever the reasons are, these patients do tend to have higher mortality risk and issues getting out of the hospital. So I think it is certainly important to think about. And I do feel like the PA catheter just is a little bit of that canary in the coal mine. It can tell you as your PA pressures are going up, if the patient's doing fine, maybe that's one thing, but if they're really starting to get squirrely on the table, this is an extra vital sign that we can pay attention to. And tells us where our trend is. If things are kind of up and down as expected with our parts of the procedure that cause more ischemia, that's great. But if the person is just sort of continuing to decline, then I think that is important information. And even if that just impacts, how long you leave the device in, et cetera. And then I do think it helps us with weaning protocols. I don't pretend to know how long these should stay in after cases, try to make a case-based decision, but I think it's an additional piece of information. This is our proposed algorithm that Jamie McCabe sort of threw a bunch of things at the wall to see what stuck initially. And then we followed this prospectively for about a year, looking at cases where we considered mechanical support for PCI. In our practice, this is almost always an impella or tandem if there's LV thrombus or other kind of clinical circumstances for that. Obviously, there are lots of patients who have come in over on a balloon pump and we've kept them on with that. But this particular cohort, we were looking more at that just based off our practice because of the independent work support you get. Over time, if we looked at that prospectively, the patients who, this doesn't mean it's validated that this is the right answer, but the patients who, as we kind of honed in on that, ended up getting support that stayed in for a little bit, or ended up getting support that was not placed up front in the case, but did get support placed at some point before leaving the cath lab. The general markers were those from hemodynamics based off high LV EDP and clinical assessment of that with new orthopnea, ischemic MR, some factors like that, as well as the ACS presentation. So not to say this is the right answer, but those are the factors we kind of lean heavily on. A lot of the procedural risks didn't necessarily come through. So not to say that doesn't ever apply, but I think it is a balance there, and probably the strongest factors in my mind that I weigh are that. The way I try to think about that a lot is, our LV contractility is going to vary with coronary perfusion pressure. We know that if we can keep that up in the 60 to 80 range, that's gonna be pretty good. As our LV EDP goes up, that's coronary perfusion pressure is gonna go down, especially if we have any concomitant hypotension during the case. And when they're sort of in this, it's not great range, but they're doing okay, thinking of more of the hibernation myocardium, I think these are the patients I sort of think about do well with a balloon pump, for instance, because they're a little ischemic. Oftentimes their EF is pretty normal. They get the balloon pump and are sent over for complex intervention by you. And I think a lot of times those patients who are chest pain free, who are clearly tolerating all this better, and can sit for a couple of days while they're coming over to transfer, I think they're kind of in that range. And once you start to really lose contractility from frank ischemia and a drop in coronary perfusion pressure, then I think that's where, a different type of support device probably makes sense. And thinking of those principles that our contractility will decrease with a decline in perfusion pressure, that's influenced by a lot of those factors, including myocardial demand. So patients who have ischemic preconditioning can tolerate this better, but certainly hemodynamics, like their LV filling pressures, are important. I think one of the ways this is most helpful for me, while this stuck home for me so much, is the first in-lab death I saw as a fellow was a 65-year-old gentleman who had a report of non-ischemic cardiomyopathy, who was admitted with heart failure. He was basically getting a diagnostic angiogram on the way out the door on home dobutamine, hadn't totally committed to an LVAD transplant pathway, is basically being continuing workup for that. They thought, well, it's been a few years, let's get an angiogram on top of the right heart cath. So his LVEDP to start with the procedure was about 30 to 35, so it was quite high. He has an ostial RCA lesion that maybe doesn't stand out a lot here, which we did IFR of, and that was frankly positive, despite the LVEDP being high. The stents deployed, and we don't save a lot of this, but he basically had a little distal edge dissection and had no reflow in the RCA. And he basically died very quickly. So I think just given his low reserve, we got an Impella in very fast, the artery opened very quickly, but despite all of those things, this was him with on the TEE, with getting chest compression. But suffice to say, his RV is just not moving. So even though he had left ventricular support, we were making moves to maybe either put RV support on or put him on ECMO, but in discussion with the primary team, he would really had discussed all these different longer term options with him at length. They and the wife felt like he would want us to stop given this unexpected complication. And so unfortunately that's what we did. So I think that just stuck home to me that it's not a scary PCI, but his hemodynamics were very unfavorable. And so a small complication, even if handled quickly, is really high risk. And so I try to think about that even more than, all the technical factors that we have to do. And really our goals are to either optimize heart failure in an already decompensated patient like this, in terms of if mechanical support can help us do that, or to support hemodynamics when we've got them as good as we can get them. And we think that reducing their ischemic burden through intervention is going to be helpful in the long run, but acutely more dangerous while we're working, and avoid our reliance on inotropes and pressors, certainly through the case, which comes up a lot in the acute patients. The best thing we have in terms of guidance from the joint kind of recommendations really looks at patients who have kind of similar idea of looking at these factors. If they have normal or only mildly reduced LV function and the PCI is not anticipated to be complex, usually these things are just something you aren't really thinking of, but just have as backup. in patients who have severely reduced EF or recent decompensated heart failure, but the PCI you think will be pretty straightforward, something we can keep the ischemic burden and complication rate low. We often don't, but you might use that up front, dependent on vascular anatomy, local expertise, and availability, as well as ECMO for concomitant hypoxemia or RV failure. So I think these are very broad strokes, and the nature of it is we all have to make decisions based on a lot of complex factors of the case. And of course, what we're trying to avoid is that kind of death spiral cardiogenic shock as we lose contractility due to hypoxemia in the myocardium, and kind of lose control of the situation that way. But that's all variable, kind of how much it takes patients to push over there. How are we doing on time?
Got about 5 to 10 more minutes.
Okay, perfect. I can just kind of go through. It just had some other cases where we were looking at some of this. I think, similar scenario. This one has kind of an aneurysmal disease into left main, into the circumflex. She was actually sent home on hospice and was referred over to us, and wasn't thought to be a candidate for PCI at all because of poor access for mechanical support. She does have this prior stent here. Her extra arteries are quite small. So I actually had sent her to my partner, who's an expert on transcable, in case she did need something like that done. But quite frankly, her filling pressures were great. I mean, she's sort of a selection bias. She had survived on hospice at home, and HOMO2 is treatment for this for about 6 weeks. So she's obviously doing a little bit better than others at this point, and really tolerated it all quite well. And I think, had a better result than having nothing done at hospice on home. So I just think, but nobody had ever thought to look at her hemodynamics to help to make this decision. And not to say that the small hospital in Idaho should feel obligated to handle this, but I think what you were mentioning as we came on, that for her, she was offered medical therapy in the form of hospice and nothing else. And hopefully the more we can work together as a community, we can either facilitate other folks being able to tackle this, or having them come here and work with us on that, or get more people treated. These are a little twitchy, so I'll play that through. But basically, she got stented into the circ. Sorry, that's being funny, and tolerated that quite well. On the flip side, I had a gentleman who had severe IPF. He has basically terrible angiograms because it's hard to see with similar aneurysmal disease. Basically, used imaging to lay this out, but I don't think the circ is all that involved. It's really just his LED. His WED was very high in the setting of severe pulmonary hypertension and low cardiac index, out of proportion to what I expected. And so I ended up putting an Impella in him that I don't know, the case went fine, but he basically could barely tolerate the Impella being in. He was having suction events, probably an element of RV failure was an issue for him. And so I don't know that that was the right answer, but at least based off the hemodynamics, I decided to do that. So I think it's a complex decision. My practice has skewed more to leaving the device, whatever it is, in overnight to let all the ischemia kind of settle down regardless of what happened. But in some of these cases, the person's having other issues or vascular events that requires us to get that out. I think last case here was a woman who had 2 prior cool-out procedures. So she basically has 4 2.5 stents sticking out into her left main. One place in the Philippines is hanging way out. So, so there's like a JL3 guide here, and that's it. And so I'd actually already taken care of her as an inpatient when she initially transferred with a balloon pump. She was doing pretty well on that. We kind of quick ballooned everything, got her out of the hospital. She was having GI bleeding at the time, just like dealt with it. And she presented very ill with flash edema, really wanted to come back and have more done to try to prevent that. So I figure now she's doing better. Her LVEP is like 8. Her index was normal before. She tolerated that all quite well with just a balloon pump. So I'm going to try to just disengage the guide every time, balloon really quickly, image, and decide how much we're going to have to do before we decide, because she was a vascular nightmare. She had already had an ischemic limb, had to move her balloon pump to the axillary, et cetera, last time. So I basically get the guide in, and I never recover from that. So you can see CPR as the Impella's going in is never a great scenario. And she ended up coming back to the lab a couple of times to work on this. She has an RCA CTO that we never did get her back down for. And she ended up being, she's in the hospital a month and all of this. And I think just to write home that there are cases where maybe my rules don't apply. And this is one where that got me, because I thought I could just be careful with guide management, balloon it really quickly, get it back out. And we just never really recovered from that. And 5 minutes later, we're putting a device in. and someone with really unfavorable anatomy, basically quickly put it in the leg, and then she got a transcaval device that she needed for about a week altogether. So, all devices are certainly not created equal, and maybe she is someone with pretty good baseline hemodynamics. Maybe a balloon pump would have been helpful. I don't know. The data and the recommendation out of Europe is that it's not really recommended for this indication, but I do wonder if there's patients where it is enough just to nudge them back on, given how well she had tolerated it before. But again, we don't really have all the answers for that. Certainly, there are patients where, because of LV thrombus or mechanical valve or mitral stenosis, where a tandem is handy to have around. And in cases where for BIV failure or patients who have other needs for it, then ECMO can be helpful with a vent. So just to say that, I don't know exactly where a balloon pump fits in. It's not really part of our algorithm for patients who have nothing in. Sometimes if they're doing well with it, I'll just stick with that if I don't think they necessarily need an Impella. With these other situations where, dedicated RV support, I think we have a lot to learn about who benefits most from that and how to manage it. So just to wrap up, I'd say mechanical support, I think the biggest takeaway for me is that it's not a crutch. It doesn't make our intervention easier. We still have to do a good job, be efficient, and try to get a good result as quickly as possible. But it is a balance of risks. But I think there are times where it really does aid us. And actually, the case that I was just doing, his hemodynamics were great, but he had a total occlusion of his LAD that's like hanging on probably by a thread. We just aren't seeing it fully integrate, and a very tight circ that's dominant. And he has an EF of 10%. So I just didn't think hard about it and put one in. And I think that helped us a lot. So no hard and fast rules, but just sort of a few cases of how we try to use hemodynamics to help aid our decision making. Thank you.
That was excellent, Kate. Thanks very much. Where does valvular heart disease play into it? If someone has moderate to severe MR, but maybe their wedge is only 20 and their index is fine, does that play in? And moderate AS also is something that we try to at least think about as we assess these patients.
Yeah, it's interesting. I mean, I think the folks who do a lot more TAVR probably have more experience than us, but as an institution, it seems surprising actually the kind of more stable outpatient with AS, kind of what they can tolerate. Again, I think we're being careful, but just because you're doing road on the LAD doesn't mean they necessarily need hemodynamic support. That can make things messy. And I think more and more we are treating patients, if you can make their valvular hemodynamics much better and the intervention is such that you're not, terribly worried about guide support and issues like that after the fact. It seems like they tolerate it quite well, but even when we've done it beforehand, oftentimes it goes well. For the patients with MR and you're concerned about ischemic MR during the case, I think they are the ones who tend to benefit a lot actually from mechanical.
Yeah, that's been my experience too. If there's a decent amount of MR to start and you're going to make it worse during the case, MCS and or anesthesia are things that we'll employ earlier. It at least goes into our algorithm. It's not often written, the ones like Jamie's and the one in ACC, but I think it's something that bears consideration.
Yeah, that's great.
Haiti Lacha asked a question about pretty much direct stenters being quick and the fact that we're incentivized to do that as interventionalists. Lorenzo took that on in the chat. Would you like to elaborate on that, Lorenzo?
Well, yeah, I mean, not much data out there to inform decision making. I don't know. I'm not aware of any study actually. For sure, it's a relevant factor to consider because for sure, just the cath lab time is an important cost item for these procedures. So, however, I think that in general, what should drive our decision making in beyond this, these differences in the economics is patient outcomes. Because if we have a complication because we wanted to optimize our procedure and just do one stage PCI, the cost of that is for sure gonna offset all the benefit of doing a single procedure as opposed to two, maybe the second one being elective. So I think that if we keep that into consideration, we base our decision making on the patient's characteristic and the characteristic of the procedure, we're gonna make the right decision.
Awesome. And Haiti, I think one of the points which you bring up is that the NCDR and hospitals look at short-term outcomes at discharge and maybe in some states 30-day mortality, but we're not incentivized to do a good job past 30 days in any way, shape, or form. And when we start to have conversations about the underutilization of imaging, and sort of non-adoption of things that we know improve outcomes for patients. I think it raises frustration of many, and I can detect that that's sort of embedded in your commentary. And so, with ongoing trials such as Illumian 4 and Ron Waxman's IVA study, after those get published in the next couple of years, there'll then be 4 mega trials done on different continents that show the value of things like imaging. And I can't imagine that it won't make it into the guidelines if it doesn't before then. And I think payers are going to start to need to look past 30 days in terms of how we do cases and how we get people to be stent failure free before you're going to be able to have a dramatic impact on that. But I think things like education, things like research, even this small study that we participated in called Light Lab, we were able to show that over 40 investigators, it only takes 9 to 10 minutes to do an OCT guided PCI with pre and post planning. And so little things like that, I think, as we train physicians to do a better job, tackle harder cases, use IVUS, use OCT, use physiology, hopefully the incentivization will follow as the data in the space grows. But you raise a good point, and I think it's a source of consternation for many of us that have embraced these technologies based on at least how we read the literature. Other thoughts to wrap up, Kate or Lorenzo? I really appreciate your time putting together 2 wonderful talks tonight and the great discussion we've had. And appreciate the people that have attended and the engagement in the chat with really good questions so far. Kate, anything to add?
I just say, I think this job can be hard sometimes, and I really appreciate learning from guys like these. I think the more, the good thing about these virtual formats is I've seen a lot more cases by a lot of different people outside of the walls I work in. And so I hope that we can continue to do that. Appreciate it.
Thanks. Lorenzo?
No, I echo Kate. I mean, it's one of the most important thing about these webinars is that we get to exchange not only among ourselves but also with the audience our experiences. Sometimes, especially in private practice, someone may be feeling like isolated in their own silo. It's difficult to interact with other peers, and I think this kind of initiative must be fostered in the community and do more of them, because this is the way to go to be able to bring the chip movement forward. And hopefully, as you pointed out, Kevin, when more studies like the imaging studies are published, then we will have a stronger case to make also financially attractive our procedure to the hospitals.
Great. And with that in mind, the chip community is highly collaborative. And so there's lots of resources in terms of how to grow your practice. I mean, Kate, myself, Lorenzo have learned this from other people who are our mentors and are very excited to share what we know and learn from people. So to echo the comments of the faculty, I learn something every time I come to a presentation like this. So really appreciate the opportunity to interact with both you and the attendees tonight. Thanks to Josh and Teleflex for sponsoring what will be a multi-part series. I think our next session is going to be on the complex PCI toolkit, building on the nice foundation that Kate and Lorenzo set up for us tonight, thinking about microcatheters, guide extenders, and some of the gear that we use to tackle these complex cases. So really nice to see both of you. Thanks for your excellent work this evening, and I'll give it up to Josh if he has any final comments. Otherwise, we'll wrap it up and let people get on with their evening. Really appreciate everyone taking time away from their families this evening to spend an hour on complex PCI with us.
Well, thank you very much, everybody, for joining. I'd like to thank our faculty and our host again for tonight. And please keep a lookout for the invites. Right now, we're looking at November 9th for the second part of this series. And we hope everybody will join us again for part 2. And thank you all for your time this evening.
Be well. Take care.
Thank you. Thank you, everybody. Bye-bye.